Thanks everyone for coming. I've been instructed to stay on time, so I'm going to whiz through this as quickly as possible. This is a great talk, Manos. By the way, this is a perfect introduction to what I'm going to talk about, and that is saving branches in CTO PCI. These are my disclosures. So how important is the side branch in PCI in general? I think this is the main question that is posed in all the bifurcation trials that we know. Using this provisional strategy versus an upfront two-stent strategy and taking care of bifurcation lesions. And I think we have some early data that shows potential trends in the two-stent strategy, but longer-term outcomes are still needed. In CTO PCI, the way we think about side branches is a little different, and it's important to consider what this means when we're doing these more complex interventional techniques. Of course, if you occlude a major side branch during a CTO PCI, that portends potentially a worse outcome for the patient because you're leaving an unrevascularized territory. In the right coronary artery specifically, distal branches are considered the main outflow of that vessel, and so potential occlusion of them may lead to higher risks of restenosis and reocclusion in that type of PCI. So it's something to consider. I'm going to go through a couple of cases to sort of pinpoint this issue. And this is a CTO that I performed last year. And you can see I've dissected down the entire artery and I re-entered here on the upper right into the PDA. If you look carefully in the upper left diagnostic picture, you can see that the true occlusion, the distal cap of the occlusion is right at the bifurcation. It's difficult to see there. But trust me, it's right at the bifurcation of the posterior descending artery and the PDA. And after putting stents in, you can see that I've lost the posterior lateral branch. Still good flow into this vessel, but what does that mean for the patient? And you know, he's done well since last year, but if you have diffuse disease in a single vessel that you've re-entered into, then the risk of reoccluding this vessel may be higher. And so our goal, I think, should be to try to maintain as many branches as possible when performing these complex interventions. I don't have pretty images like like Manos videos, so forgive my crude images. But just so that we're all on the same page, the top left represents the occlusion of a coronary artery right at the bifurcation of a major branch. And if you see on the right, we dissect into the wall of this vessel, cross the occluded segment, and then re-enter at some point when we have a true lumen to re-enter to. And you can see in this specific example, the re-entry point is past the side branch origin. And so if you implant a stent, this is the potential outcome, and that is loss of flow into that side branch, something we try to avoid. This is a CTO PCA that I just recently intervened on a few weeks back, actually. Patient presented, a previous bypass patient, with occlusion of his vein graft to his right coronary artery. On the left, you can see the right coronary artery occlusion, which has been there for more than 10 years. And I highlighted the occluded segment in black on the right, and the distal vessel, which reconstitutes into a diffuse disease distal segment before bifurcating. And so the goal here for us is to try to do directed reentry right into that diffusely diseased segment proximal to the bifurcating segment to try to save both of those distal branches. You can see me dissecting in the top left-hand picture and then re-entering in the middle picture. And the final picture here on the bottom right showing salvage of all the distal vessels with a good patent AV groove vessel. So very pleased with that. But the idea, again, is to have very precise directed re-entry. This is another case, an LAD CTO, dual injection here. You can see the left anterior descending artery on the top right, the occluded segment, which is more than 20 millimeters. And if you pay close attention, you can see here, I've outlined the occluded segment, which is a second diagonal vessel that is filled by the right coronary artery collaterals. Okay, and you can see the stingray balloon right here, I placed it right at the bifurcation, and you can see me on the right in the video trying to re-enter right at the bifurcation, trying to avoid re-entry past the second diagonal, okay? Again, trying to save a major side branch there. And you can see final result there. So there's a dissection right into that, that diagonal branch, but still some flow in an antegrade fashion, so I was pleased with this outcome. So when utilizing these complex techniques of dissection and reentry in CTO-PCI, I think the reentry techniques have to be deliberately precise to allow salvage of important side branch vessels. Thank you so much.